say at the outset that the meeting is being recorded for future upload to our web, and to remind board members and participants to use the show hands facility to speak at the meeting rather than the chat function. Are there any apologies, Ruth?
Thank you, Boyd. Yes, we have an apology from Deirdre Mackay. We also have an apology from Heidi May. And I was under the impression that Kate Patience-Quate would be in attendance, so I'm just looking for her on the participants list.
She is. She is.
Excellent, lovely, thank you.
Thank you, Ruth. Any declarations of conflicts of interest? Alistair.
Yes, thank you, Boyd, and good morning to everyone. I had considered making a declaration of interest in my capacity as a Highland councillor. However, having applied the objective test and looking at the items on the agenda, I feel I don't need to do so. Thank you.
On to item on staff recognition, and today on primary care through.
Sorry, Boyd.
Want to come in?
I think Gaina had her hand up.
Want to come in?
Sorry, yes, it was just to say I had also thought about making a declaration of interest in relation to item 13. Just to point out, I was up until July 2020, the chair of Highlands Children's and Young People's Forum, which is talked about in the report because they do a lot of work in helping young children and young adults find their voice. But I had no part in that piece of work or the report in item 13, so I'm happy to remain. Thank you.
Thanks, Gaina. Can now move on to item 3, which is staff recognition. And our focus today is on primary care. And I'm very pleased to welcome some primary care colleagues who will describe to us their experiences throughout the COVID pandemic. We have the following colleagues with us: Jill Mitchell, who's head of primary care for North Highland; Cora MacLeod, optometric advisor and hospital optometrist, head of service; Dr. John Wallace, GP in Fort William, who's also the district medical lead for Low Harbour; Rebecca Helliwell, deputy medical director for Argyll and Bute; Paul Davidson, deputy medical director for North Highland; and Joyce Robinson, who's the primary care manager in Argyll and Bute. I'll now hand over to Jill to introduce the item. Welcome, Jill.
Oh, many thanks, Chairman, and lovely to be here today to talk to you all. There are 4 pillars of our primary care family. Today we're going to talk about general practice and community optometry and our experience through our pandemic response, but also focusing a bit around remobilisation. We are hoping to come back to a future meeting to talk about community pharmacy and dentistry, because we're conscious we didn't have time today to cover everything. So John and Rebecca and Cora are going to give a brief presentation this morning, and Paul, Joyce and myself will join the second half of the session to answer any questions or queries that people have. So without further ado, I shall hand over to Rebecca.
Good morning, everybody. My name is Rebecca Honeywell. I'm a GP and a rural practitioner in Lochgilphead, and I'm also Deputy Medical Director in Argyll and Bute. I'd like to start the presentation today by asking you to cast your mind back to the very different world of 2019. We didn't really start the pandemic in very good shape. General practice was under a lot of pressure. There were issues with access, continuity challenges, difficulty meeting public demand, increasing medical complexity, multimorbidity, polypharmacy, funding gaps, a controversial new contract, recruitment and retention challenges, and always a challenge of our geography. So we weren't really, apparently, in terribly great shape for a huge new challenge. On to slide 2, please, Ruth. I have to say that sometimes a massive common threat unites us, and it was really amazing to see the dynamic transformation of general practice across the whole of our system through really combined efforts from everybody. Our estates transformed overnight virtually. Physically, infection control measures were implemented, perspex screens appeared, we had new flow routes through all of our buildings, and social distancing in waiting rooms, etc. Our staff had to adapt to PPE. The at-risk staff were shielded, and practices started to develop buddy arrangements with their neighbours so that they could maintain continuity if that was at risk. And IT was very helpful in this regard. So we were getting to grips with identifying a new disease and learning about it and how to spot it, what treatment was needed, new protocols, directives, clinical pathways, and keeping up with all the government guidance was a really full-time job in those early days. GPs led a lot of the shielding work, identifying folk and ensuring that they could get care too. And we had an initial pause with people presenting to our surgeries, but really virtually overnight, we moved to phone consulting in the first instance, meaning that people could still access us, albeit very differently. And that was a huge learning curve for us and for our patients. But we really needed to do it to minimise the risk. And it meant that general practice was always open. We worked with our pharmacy colleagues to prescribe differently so that we were avoiding bits of paper. We emailed sick lines, all to avoid footfall into the surgery to protect staff and the patients who did need to come in. You can see in the bottom slide in this picture the results of telephone consulting and how we made that work, and it just what phone consulting can do. Initially, the anticipation was very, very stressful. It was very concerning for everybody. We updated care plans. We thought lots about resuscitation. We planned mass palliative care potentially in case we needed that. And we were working very hard on how to protect our most vulnerable groups and developing systems, for example, for care homes and consulting by video. There were some things we stopped doing, enhanced services, for example, evening surgeries happened less, and we probably did less chronic disease checks as well. But always there was this background niggle about personal safety. One of my colleagues summed this up, turning to me just as he walked PPE clad in to see somebody, and he said, "This is the moment it always makes me think, could this be the one that does me in?" The deaths from COVID of a local paramedic saddened and shocked us and felt very close to home. The red COVID pathway stood separate to general practice as a whole, but alongside it throughout the whole pandemic. I'm going to hand over now to John Wallace, a GP in Fort William, to tell you a bit about his experience.
Madam Vague, good morning, board members. In March 2020, in the north of Scotland and the west of Scotland, we looked with horror, with sadness and with fear at the scenes in the north of Italy and wondered what it would be like when COVID inevitably came here. COVID did come to us, but it came perhaps in a different way than we initially expected. And perhaps no more so than our experiences over the past year, the old cliche that we are facing a marathon rather than a sprint was something that we had to learn again and again. If we take ourselves back to March 2020, we noticed huge changes within general practice. Even walking into the building, the magazines in the waiting room, which were once a ubiquitous sign of perhaps frustrated patients waiting to see myself as I struggle to keep up to time, were all gone. Highland GPs sometimes ditched their shirts and jackets and replaced these with scrubs. As Rebecca said, we needed to move very quickly to a different model of access, and we moved to a total telephone triage. But it is important to stress within that we did see patients face to face throughout the pandemic, and certainly every day that I've been working on clinical duties, I have seen a patient or more than one patient face to face. But I'm going to particularly focus on how we dealt with respiratory symptoms and potential COVID in general practice. We know that the symptoms of cough and fever, which were the initial cardinal symptoms indicating a potential COVID infection, are incredibly common within general practice. They are our bread and butter. But yet, in the space of a few weeks, we needed to find a completely different way for safely managing these symptoms. We had a national directive from the Scottish Government and NHS Scotland that we were to set up a COVID pathway, which would be a Once for Scotland pathway run with patients accessing services via 111 and NHS 24, and calls being passed to experienced primary care clinicians within the Highland Hub based alongside the out-of-hours service in Inverness. These experienced clinicians have done a power of work over the last year, phoning patients with potential coronavirus and deciding which patients require further, more detailed face-to-face or hospital level assessment. In terms of arranging face-to-face assessment, this proved particular challenges for our geography. The national directive was that we should set up district community COVID assessment centres that would be distinct from general practice. But clearly, with our geography, we needed to find a balance between proximity to the patient and the numbers of centres we could sustainably manage. Within North Highland, we set up 6 sites, and these sites were clinical cover was provided by primary care clinicians, GPs and ANPs throughout Highland. As time moved on, though, we realised that the pandemic that was coming our way was going to perhaps be here for a lot longer than we initially anticipated, but we were going to have to live with it in a slightly different way to what we first thought. And we realised within North Highland that we needed to have some flexibility within our model. We needed to make some tweaks and some changes, and thus along with GP colleagues, we reverted to seeing most during daytime working hours, most patients with a cough or a fever within protected red rooms within practices themselves, thus bringing the care closer to the patient. The CAC service, however, continued to run and morphed and developed and flexed to become a cornerstone of our testing strategy within Highland. In the early days of testing, accessing government testing sites within the rural areas was particularly challenging, and the CAC nursing staff particularly stood up admirably to take on that work. I would particularly commend the work of the out-of-hours service and the Highland Hub, who have done a power of work in developing this pathway, and also most time-wise, many contacts to the national COVID line occurred during the out-of-hours period. COVID would come, but it came in a different way, and this has been a learning experience. There were changes as the pandemic went on. We realised that we needed to ensure that we did not neglect non-COVID care, that we focused on mental health, that we prioritised care homes. It was exciting to get news of how effective the vaccinations were, and primary care clinicians, along with nursing and dentistry and some other colleagues in primary care, have been at the forefront of delivering the vaccination programme. But yet, just when the excitement of vaccination had come our way, we learned of a second, more infectious wave, which in numerical terms was going to hit parts of Highland much harder than the first wave did. And it was during that experience that my own personal professional experience of seeing COVID patients who became very quickly unwell, and seeing their deterioration in front of them, and seeing how the system worked and how we worked with secondary care colleagues in the hospital and the Scottish Ambulance Service, and being able to follow their journey through it. But it was there that I really learned so much about this condition that we have, that we know has changed our lives so much. And I think it has emphasised to myself the importance of these strong networks between primary and secondary care clinicians and other colleagues. So we're now entering into a new phase. We don't quite know what the future will hold. We know that work within primary care is very busy. We are getting a lot of calls. We are seeing a lot of patients face to face. We know that there are risks. Our staff are getting fatigued in places. There is a lot to do. There is a lot to rebuild. But I would commend that we do have a lot of lessons that we have learned over this past year of the value of our generalism within Highland, of our flexibility, of our ability to adapt, to work together, of our focus on mental health, and of the cornerstones of good compassionate care, and of the benefits of continuity of care by clinicians who are committed to their communities. I would like to thank the board for this opportunity to speak briefly to you. Thank you.
So moving forward, John's already alluded to the last few months being all about vaccines, and general practice has largely led the delivery of about 321,000 doses of vaccine in all corners of our patch. And they've had a hugely positive impact on us in general practice. For many staff, it's been the best part of our week. And it was very emotional for us seeing all our oldies turning out in Sunday best for the first vaccine clinic. And it's been great to have staff who feel a bit safer and a population who are a bit less fearful when we say we need to see them. So as John says, moving into more board-led vaccine times, we're trying to work very hard to mitigate and balance the harms that came with the pandemic. Some of the bits that were the non-directly COVID impact. So inequalities of access and the impact of reduced services in secondary care and longer waits for people to definitive treatment. And people are now picking up the more minor issues that they were happy to pause when there was more COVID around. We're daily seeing the impacts of isolation, loneliness, reduced activity, especially in our older patients. Our teenagers are anxious and stressed, and nobody has escaped the psychological challenges that COVID's brought them. So we're seeing increased substance misuse, poor mental well-being, and challenged coping mechanisms. I've never known a greater demand and suffering in our population, and the strain that we're under in general practice is very palpable. So now more than ever, we're needing to create future models that are sustainable and balance the health needs of our population with the capacity that we can offer. The issues we had prior to the pandemic really haven't gone away. Some are worse, but there are some different ways of working during COVID that might help us develop and move forwards with some of those issues. Implementing the new contract for GPs should bring greater support and a more multidisciplinary approach to practice, which we're going to need as we recover and restore resilience for us all, so that we can continue to provide quality general practice to all the population of Highland. I'm going to hand over now to Cora, who's going to tell us about community optometry.
Hello, Ruth, if I could possibly have the next slide, that'd be great. Many thanks for inviting me today. Oh, sorry, next one after that as well. Many thanks for inviting me today to discuss the impact of COVID-19 within community optometry. Across NHS Highland, there are just under 250 optometrists listed to provide general ophthalmic services, working across 43 optometry fixed premises practices, peripatetic practices covering 12 remote locations, and also 7 mobile practices providing domiciliary eye examinations in day and residential centres, and also in the patient's own home if required. Firstly, may I give you a very brief history of community optometry to provide some context. When the NHS was launched in 1948, there was provision for sight tests via supplementary ophthalmic services. The initial plan was for these services to be provided within the hospital eye service, but due to resource limitations, supplementary ophthalmic services were moved into primary care. In 1968, these services were renamed as General Ophthalmic Services, and in 1988 saw the universal sight test provision withdrawn and limited to those in specific age groups were receiving certain state benefits. A significant legislative change occurred in 1999 for optometry, which removed the legal requirement of referral to registered optometrist if any ocular abnormality was detected, enabling optometry. In 2006, Scotland returned to the founding principles of the NHS and reintroduced universal eye examinations. This provision enabled general ophthalmic services to be delivered flexibly and appropriately to the patient's needs due to two different examinations versus the previously limited sight test structure, which still remains in England. The Scottish Government's Community Eye Care Services Review in 2017 highlighted that the introduction of universal general ophthalmic services in 2006 had enabled optometrists to be first port of call for people with eye problems and had introduced a fundamental change. This fundamental change has resulted in community optometrists being recognised as a vital part of the wider health and social care service, something very much highlighted over the past year. The impact of COVID-19 within community optometry has been significant. Up from March 2020, routine domiciliary eye care was ceased with immediate effect, and 11 community optometrists providing emergency essential eye care only. Changes to general ophthalmic services were rapidly introduced on the 25th of March, enabling inter-referral to independent prescribing optometrists, but also telephone consultations. However, due to the limited national PPE stockpiles that had not accounted for community optometry, 2nd of April, NHS boards were directed to establish designated emergency eye care treatment centres, or EETCs as they became known, were to provide face-to-face emergency eye services to further reduce the risk to patients and also staff. An EETC could be a community optometry practice or situated within the hospital eye service. After consultation with NHS Highland and NHS Greater Glasgow and Clyde ophthalmology departments and relevant primary care teams, 5 optometry practices in Orkney and Western Isles were designated as emergency eye care treatment centres. Both ophthalmology departments in NHS Highland and Greater Glasgow and Clyde also acted as EETCs. The number of optometry practices selected to become EETCs was extremely limited due to the limited availability of PPE and selected on their geographical location and, where possible, having an independent prescribing optometrist available. All 5 optometry practices were supported with teleophthalmology technology and were operational on 6th of April. As additional PPE became available, additional EETCs were established, enabling the ophthalmology department to cease being an EETC on 25th of May and concentrate on remodeling for those most in need. Due to increasing supplies of PPE within the NHS, on the 29th of June, EETCs ceased and all community optometrists turned to providing face-to-face emergency and essential eye care. The return of routine eye examinations in practices and patients mobilising from the 3rd of August. However, resumption of domiciliary provision in day and residential centres was not permitted until peripatetic services were only permitted to restart provision in November. Considering the past year for community optometry has indeed been very challenging. Nationally, the lack of PPE limited general ophthalmic services delivery in the early stages of the pandemic. Prevention control was a fairly daunting new subject for most optometrists. However, NHS Education Scotland and Health Protection Scotland helped, but also did cause confusion. Social pressures have been and continue to be a significant concern. The financial viability of practices have been a concern. However, national support payments have been invaluable for the scheme. Businesses have also had staffing challenges, from furlough to shielding, self-isolating, childcare issues, and of course, probably most importantly, individual staff's apprehension and fear. Locally specific challenges have been the low numbers of IP optometrists across NHS Highland, where we only have 9 in community optometry. Secondly, practice rurality has also been challenging. Please skip on. Can we have the next slide? So this map was published by NHS Education Scotland in 2013 and published in the Optometry in Scotland Workforce and Education Report. It identified that almost 2/3 of the population are within 5 minutes drive time of their nearest optometry practices. However, as you can see, there are large areas of NHS Highland and the Outer Island wards that are in a deep red. This represents a greater travel distance of more than 30-minute drive to the nearest optometry. This, of course, brings significant access challenges for patients, but also professional isolation. Of course, however, in the midst of every crisis lies great opportunity. No longer are community optometrists providing supplementary ophthalmic services, as it was termed in 1948 part of the NHS, but are recognised as an essential part of the healthcare service. The past year has highlighted that primary care support and optometry professional leadership is valued and needed by community optometrists. The e-health developments in recent years, including NHS e-referral, e-payments, Near Me and emergency care summary, have also demonstrated this area of primary care is a vital part of the wider NHS service. Primary and secondary care collaboration has increased as demonstrated in the EETCs. As a result, the ophthalmology are increasingly engaged in discussions and delivery of NHS Education for Scotland teaching complex and also IP placement opportunities for community. Also improve regional working with both NHS Orkney and NHS Western Isles, and indeed across all health boards through the National Scottish Optometric Advisor Group. There are huge opportunities ahead for new ways of working. The National Treatment Centre and e-health developments such as the National Ophthalmology Electronic Patient Record and Care Portal will facilitate innovation and service delivery. Indeed, community optometry is now not in the peripheral shadows of the NHS service. Regular ongoing engagement between the Health Board and Scottish Government colleagues will shape the anticipated General Ophthalmic Services Review within the parliamentary term, and improved integrated working will deliver improved patient-centred care. Thanks very much for listening. I think that's the presentations concluded for primary care, so it's a bit of time for any questions that you have.
Thank you, Cora, and thank you all for your presentations. And this is an opportunity now for us to ask questions. So invite colleagues to ask questions. And we also have Paul and Joyce, as well as the presenters present. Anne, first question from Anne.
So I was interested that a number of you mentioned the e-health developments and moving to remote working and more use of triage, etc. I have heard some different opinions about the use of remote technology in primary care. So I would really like to hear your views of what the most appropriate way forward for the use of e-health in primary care is, where the greatest opportunities lie, but also what we need to do to ensure inclusion of those people who perhaps find it more difficult to use these methods or don't have access for various reasons. Thank you.
Rebecca, Jill, who do you want to answer that?
Yeah, Rebecca or John, it would be helpful to have your views because you've been at the front line of using remote consulting.
Absolutely, I'm happy to comment on that, and thank you for that question. I think it's a hot topic in general practice, and access is really important to us because we do recognise that we are not necessarily reaching all of our population equitably sometimes, During the pandemic, we've kind of experimented, I suppose, with different methods of communication. Most practices, and certainly I'm speaking for the practices in Argyll and Bute, have found that the telephone is a very, very useful means of communication and working out how to get that person the help that they need, either supported over the phone or brought in to see the most appropriate person. So telephone has been very useful. We found video more difficult. In some situations it's very, very helpful, but generally it's a bit more clunky, and we found that it hasn't really particularly been a particularly useful tool for primary care. There are situations where we found it useful, for example, in nursing homes, district nurses with iPads can show us what the patient looks like and help operate the tech and get familiar with that. So there are situations where it's useful, but probably less so than simple telephone mechanisms, basically. And I think you know we haven't got this back yet. There are certainly things that we could do to improve it, but we're all learning. But that was my experience, certainly.
Thanks, Rebecca. Does John want to add to that?
Essentially, very similar to Rebecca. I mean, I suppose the best thing is a shared decision between the clinician and the patient as to what's best for them. I think I find that very often when triaging calls, if I know the patients well, video maybe doesn't necessarily offer an awful lot. We either telephone them and we can deal with it, or we need to see them face to face. Having said that, in the earlier stages, particularly with some more sort of mental health type issues with patients who are maybe fearful of coming in, understandably, during the pandemic, I think it was helpful to be able to see the patient face to face and use their body language. We sometimes find photography can be helpful for dermatology, for sort of skin related conditions, and I think within our practice we're moving towards doing some of our asthma reviews via video. Asthma reviews sometimes require you to blow into a peak flow device and demonstrate how you use your inhaler, and because of COVID restrictions it would be safer to do that over a video rather than in the room. So I think it has its place, but amongst everything else, and yeah, we obviously I think we do need to take into account the patient and not prejudge the patient. Some older people are very adept at using technology, but some people it's another stress. If you're about to get an appointment, it's an additional stress that most people are fairly comfortable with using the phone, but less so perhaps with the video technology.
Next question is from Sandra. Sandra represents UHI on our board.
Thank you, Boyd. It's not so much a question, just a point of information, if I may, just about optometry. Just in case the board aren't aware about the BSc Honours programme in optometry within the University of the Highlands and Islands, taking the first lot of students in with 10 students and taking a staggered approach to that. Ultimately going to have 60 students with 40 in Inverness, 20 in Moray College in Elgin. The staggered approach this year, we're offering 30 places. We had twice as many applicants for these places that we're able to offer. And these will be location and case-based training around Highland region. And in terms of, Cora mentioned about the National Treatment Centre, we are in discussion with Deb Jones from the Treatment Centre in Ophthalmology about opportunities for interaction, research and education between ophthalmology and optometry going forward across UHI and NHS Highland. Thank you.
Thanks, Sandra. Alex and then Boyd.
Yeah, thanks, Chair. Firstly, thanks very much, folks, for all the great work that you did through the pandemic up to date, and obviously there's an awful lot more to come. And the vaccination has been a blessing. Do you see a problem in future where we're going to have potentially boosters for certain parts of the population? We're going to have, I think, an increased uptake in the flu vaccination, particularly in the more vulnerable, plus the remobilisation, plus more people coming to see you, because our demographic is not going to change very much. We're going to get older rather than anything else. How do you see you adapting to those pressures, particularly bearing in mind that at least for the foreseeable future, you're still going to have social distancing, face masks, etc. Thank you.
Chair, I don't mind coming in and answering that in the first instance.
Yeah.
Rebecca mentioned we've got a modernisation programme which is attached to the new GP contract, and one of the work streams certainly that we haven't progressed with at the moment and we are looking at is how we transform vaccination delivery. So there is a bit of a programme around that and thinking around, you know, what needs to be developed as a board to support our general practice colleagues going forward. So it is something that's under active consideration at the moment.
Thank you, Jill. Boyd.
Thanks. So like others, I particularly want to give my gratitude to all of the clinicians and other staff in the community services who have had a tiring and challenging now something like 14 months of pandemic, and it's very clear from even the questions just now that it's been a game changer, and it is a marathon, as John said, and it felt like a sprint that never ended, and it's just changing, and what has to happen will have to change and adapt as well. I just thought I'd just chip in, perhaps some of our colleagues could comment on how in the Highlands we probably will have an upsurge in people vacationing at home, and that means inevitably that it's going to affect the service delivery in Highland, because of course we will be, I suspect, even more popular this year and next year than we have been previously, and how that might affect services in communities right round the Highlands.
Jill, who do you want to answer for that?
Yeah, Joyce, do you want to come in and talk about temporary residents and what we do to support people who come and have holidays in this beautiful part of the world?
Yes, thanks, Jill. Temporary residents are treated like any other patient when they're living in the area, so general practice is very used to dealing with temporary residents, and I do take Boyd's point that there's likely to be more in the future, but there's no difference in the GP contract to the services that are provided to those that are staying within a practice area. So it is something that, you're right, we will have to take cognizance of, but those patients who are holidaying in the area are able to access treatment if they are required, the same as any other patient. I don't know if Rebecca wants to come in or anyone else.
Just to say perhaps that practices in Argyll and Bute have been quite proactively trying to communicate with temporary residents in the area to make sure that they can access testing as required and these sorts of things to keep our local population safe, to provide that communication that they need, because if they're in an unfamiliar area then it's difficult sometimes to know how to access services. So certainly across Argyll and Bute, the practices have developed a few tools they've been using on their practice websites and these sorts of things, and comms have been helping us with messages about lateral flow testing before people go to islands and these sorts of things.
Thank you both. Graham Hardy.
Thanks, Chair. This question is directed at Rebecca. Again, thanks for all your hard work. I'm a local councillor in Helensburgh Central, and I was just wondering, from a council perspective, how helpful the council Argyll and Bute at all were in assistance with you during the pandemic. If you could, thanks.
Well, as you know, we're set up in Argyll and Bute in a health and social care partnership, and that's been absolutely the basis for all of what we've been doing within Argyll and Bute. Clearly, a lot of the sort of medical stuff or the clinical stuff has been delivered through NHS Highland, but there's been a huge amount of interface working between the partnership, basically. There have been lots and lots of issues that have required resilience partnership input. For example, the thing that springs to mind is temporary mortuary capacity and some of those things. So we've had lots and lots of discussions. We worked very, very closely together, and actually the integrated way of working has been to great advantage for us. I think we've benefited from the best of both, really. The other thing that's been very concerning in Innergang and Bute has obviously been our proximity to Glasgow, which clearly is, it's been something that we've seen as a bit of a risk during the pandemic, and certainly in the first wave we experienced in Innergang and Bute a fairly steep learning curve that our colleagues in the north were less familiar with, and that allowed us to actually work together and share lessons, so that when the second wave came and the north was more robustly hit, I guess, we shared learning, and a particular example of that would be the nursing home outbreaks that we had in the first wave that didn't come to the north until the second wave. So I think there's been some huge advantages in working together, both all the way across NHS Highland, but also between the council and NHS Highland within our Innergang and Bute.
Okay, thanks, Rebecca.
I think the same holds true of North Highland too, with the cooperation between the council and ourselves. Bert. Bert, you're on mute.
Sorry about that, Chair. Firstly, thank you very much to all of you for coming to join us this morning and for a very comprehensive and informative input. But more importantly, thank you to you and all of your colleagues for their very sterling and admirable efforts throughout the duration of these difficult times that we've been dealing with. I had 2 points. One has actually been addressed, and that was in relation to service delivery with the likelihood of staycations. My second point, however, we've had the different waves of the coronavirus, but we also hear and read about the impact of long COVID. And I just wonder perhaps if you can tell us a little bit about what you're seeing in relation to this and the impact that it's having on you and indeed on your patients. Thank you.
John, do you want to pick this up and start?
Yeah, I mean, certainly we know that COVID has significant impact, not just in the initial acute mortality, but also within the significant ongoing morbidity and what we would term long COVID in the post-infectious phase. My own experience is probably relatively limited. In Lochaber, we've probably had smaller numbers of COVID cases than some other places. Certainly, we have got a few patients who certainly come in with symptoms, fatigue, ongoing breathlessness, cough, muscle aches, and to some extent, a lot of that is the type of presentations that come to primary care. So primary care strength is dealing holistically with patients, with all their symptoms, with the uncertainty as to how things are going to evolve, with perhaps not having a simple prescription you can prescribe that will quickly make things better. So part of our commitment as primary care clinicians is to walk with the patient during these difficulties. Certainly, I'm aware from some of the discussions I've been involved with via the clinical interface group that there is quite a bit of work going on about a long COVID pathway, and I suppose it does just bring home to us the need to focus in everything, not just COVID, on the rehabilitation services, the physiotherapy, occupational therapy. We can get very sometimes caught up in the acute. Whenever we look at any redesign project, we look at the acute side of things, which is undoubtedly important, but it does bring home to us the need to invest in the ongoing, the rehab, the psychological, the physiotherapy, occupational therapy, all these things, which are lessons far beyond COVID.
Thank you, John. We're about to embark on a strategy review, and I think some of the points you made there will be very pertinent in that context. Okay, I think that's all the questions I have now from colleagues. And can I just take this opportunity of thanking you all for your contribution to our meeting today. Not just for your attendance, but to pay tribute to the exemplary work that you undertake, and your very direct experience in some cases of what happened during the COVID pandemic, but also the other functions that you perform in support of the primary care service. That's very important as well. And as somebody who's used the optometry services, Cora, I have a special interest in your work, and it's fascinating to hear that. And I'm sure the same could be said of dentistry as well, and the way that it has had to react. But that was a fascinating insight into the pandemic and some very direct and real experiences of colleagues that Rebecca recounted there. And I know from reading the press of the cases in Lochaber, people who have suffered greatly during the COVID period. So thank you from my colleagues on the board to you all for the wonderful work that you have done and continue to do, not just during the pandemic, but in the recovery phase from the pandemic as well. So many, many thanks for coming along, and many, many thanks for all the work you do on a daily basis.
Thanks, Chairman. We're really proud to have played our part and, been hidden away in the community. So thanks for your time today. Really appreciate it. Thanks very much, everybody.
We'll happily have you stay for the rest of the meeting if you so wish, but I'm sure some of you at least will have to rush off to appointments very soon. Bye for now. We move on now to item 4, the minutes of the meeting of the 30th of March and the action plan from that. And we had some revisions to the original minute, and these were circulated, I think, yesterday by Ruth. So rather than go through it page by page as we normally do, can I just ask colleagues if they have any further amendments that they wish to make to any part of the minutes? I'm not seeing any hands, so can we therefore take it that we approve the minutes? Yeah, I think I'm seeing some thumbs up. In terms of the action log, Ruth, any points that you would wish to draw attention to in the action log?
Thank you, Chairman. No, nothing in particular. Some of them are actually being dealt with today, so you'll see some change in that particular action log for future.
Okay. Are there any matters arising that aren't covered by substantive items on the agenda?
Boyd, it's Pam here. I've got my hand up, but I'm aware there seems to be some glitches this morning, so you might not be able to see it. It was just going back to the action log in terms of item 8, the Highland Partnership Agreement, just to update that we've done the consultation and that hasn't come back with any material changes being required. So I'll get an update on that this week, and hopefully we can get that signed off and sent on, and I'll liaise with yourself with regards to that. And also in the second part of that item, we will be taking forward some sort of regular slot with the board members in development around what emerges from the Feely report. So we'll have a plan going forward to try and keep people cited on that and be able to discuss it.
Thank you, Pam. And can remind colleagues to take hands down once you've spoken. Any further matters arising? No, I don't see any hands up for that. We move on then to item 6, to the Chief Executive's report, Pam's report.
Okay, thank you, Chair. I suppose there's probably just three things I want to update you on this morning. I suppose the main thing going on for us just now, the main thing emerging is remobilisation. And we are just waiting for permission to be able to publish our remobilisation plan. So hopefully that will come out in the next week or so. And we will also then be working to a revision of that in September. So people will be aware of the concerns around the fact that we've now twice in 1 year had to suspend, particularly elective surgery and outpatients running at a slightly different pace because of all the COVID restrictions. However, we are now trying to look at how we step that up and rebuild that and get back on track with the backlog, and that's no mean feat. So it's very much the focus of our discussions, both locally, regionally and nationally, looking at what all our options are to be able to bring some pace to that. As we know for members of the public, for our citizens, that some of these are really difficult for them. They're sitting with difficult situations waiting on procedures, and we want to try and as quickly as possible resume a level of normality that addresses that. But we are looking at how we do that in a collective way over the current remobilisation plan. So I think that's important to highlight, because it probably is of great concern for most people in our communities, and we recognise that. But the journey back is a challenging one, and we are doing our best to address that. The second item that I want to draw board members' attention to is the care home report that came out last week that reviews the authority to discharge from hospital to care homes, and just to be aware that that's now out in the public domain with recommendations that we are working very closely with the Mental Welfare Commission and with the Scottish Government team in relation to those recommendations. I think the key message out of that report is that there are some consistency issues across the country in terms of how the law is applied, and that the learning and the action that needs to be taken is set out within those recommendations, and we will be focusing on that. In terms of Highland data that wasn't submitted within the timescales, there was a bit of context to that in terms of the interpretation of the ask, and we are now working closely again with the Mental Welfare Commission in relation to what our local profile looks like and what actions specifically we might need to take. So it's not that we're out with the process, we were out with the reporting process for it to be included in the report, which is unfortunate. But we are addressing that, and we are reviewing our figures in that context, and we will at some point in the near future have that go through our own governance arrangements, and the board will be made aware of the outcome of that too. The last thing I want to mention is really just that for some of us, we've started to go out and about to meet with services to try and get a bit of a temperature for the organisation, and that is all done with safety and in terms of testing prior to visits to services and ensuring that we observe distancing, etc., and wear the appropriate PPE. So I myself, with Boyd as chair, have been out to Skye to see the new Broadford Hospital and to meet the teams locally there and the teams in Portree. We've also been up to Caithness to meet with the hospital staff and gone around the hospital, and I know that Louise and Alan Wilson have been also up to look at the estate in Caithness and also to meet with mental health services. We've also been to Argyll and Bute just 2 weeks ago, and we visited a number of different arrangements there, including the island of Islay. And I think on all the visits that we've done, it's been really impressive. Again, the responses of the teams, how the staff are approaching their work, the dedication, the compassion, and the commitment that comes through when you meet with them is really compelling. And we are looking at how we can buddy up execs with board members to continue a programme throughout the rest of this year to get that visible leadership truly in place. And also, it's just the joy of being able to do it. So those are the things that I wanted to highlight this morning. happy to take any questions. Thank you.
Thank you, Pam, and I can vouch for much of what you said there in terms of visits to Skye and Argyll and Bute, and the commitment and dedication of the staff we met, and also the models of care that we encountered, notably in Argyll and Bute and Isla and in Lochgilphead. In fact, in the very practice that Rebecca works in Lochgilphead. Are there questions for Pam? Any questions for Pam? Adam?
Thanks, Boyd. Thanks, Pam. Pam, you said about kind of you're exploring all avenues, or we're exploring all avenues with regard to remobilisation and lengthy waits and so on. I wonder if you could just expand a little bit on the kinds of options and possibilities being considered.
Yes, I mean, this is very much a national discussion as much as it is a local discussion. So we have put in place I guess the best we can do with the resources we've got and the restrictions we've got and the pace at which we can go at. And the government have been very, very supportive of us in terms of additional resource. And so we've had this before, where we've had, you know, additional theatres brought on site and sometimes additional staff or funding to make change in order to facilitate a greater outcome. So locally there are some initiatives. Nationally and regionally, the ask is around what we can do collectively, how we can work with each other or utilise each other's resources to the same effect. And some of that is just being explored at the moment. You'll know we've had recent examples of urology and Dr. Gray's and you know, initiatives like that. So we are looking at every which way where there are opportunities to work together to deliver the procedures more swiftly if possible. But we have quite a lot of working out to do, and nationally this is a priority with the Integrated Planned Care Board, and they're looking at the wider picture as to what other opportunities might be there. And of course we will try and play very well into that so that we can benefit for the citizens of Highland.
Thank you, Pam. Sandra, is that a legacy hand, perhaps?
Yeah, I don't see it on my screen.
Okay, that's it off now. Right. Any further questions or points for Pam? If not, can we move on to item 7, the culture programme, and an update on that from Fiona.
Hi there. I'm hoping you can hear me okay, because we just had a power cut and the broadband's just restarting. So
okay,
I'll hopefully be able to continue on the 4G signal.
Can hear you fine, yeah. I seem to have lost you again, Fiona. Gremlins have struck. David, I wonder if we could move your item up to a place on the agenda. Sorry, short notice for you. Are you able to take the integrated finance and performance report just now?
Yes, happy to do that, Chair. Thank you.
Thanks, David.
So colleagues will have a copy of the report in the papers. You'll recognise that this report has been circulated and the information it contains circulated through the relevant subcommittees of the board for review, and therefore this is a compilation of what has been taken to those different subcommittees. Secondly, you'll also recognise this is a plan that takes us, or the reporting, it takes us roughly to about the end of April in some cases, or rather the beginning of April, and really is at the year end, if you like, for most of the metrics that we have, recognising that the new remobilisation plan that Pam referenced earlier will be published in due course, and that the metrics for this coming or the financial year that we've now entered will be reflected in the next report. So there's a lot of work to be done in terms of updating the data for that. We're also taking feedback with regard to the formatting, and particularly looking at the use of control charts as we were reviewing together in the last number of weeks. So they're not applicable in every case, but nonetheless we'll be looking at where we can usefully adopt them in terms of the reporting. So always keen to get feedback on that, and that will be an evolving process. But if I can, what I'd like to do is follow a similar pattern in terms of giving opportunity to the chairs and the exec leads of the various committees as we go through. So if I can come first of all to quality and patient safety elements, and come to our clinical governance team, which is, if I can hand over to Boyd and Gaynor and Kate for just a brief introduction, and then open it up for questions.
Thank you, Chair. Thank you. I'll start the ball rolling. Boyd Peters, Medical Director. The IPQR is in the papers, and I will maybe focus today on complaints, which is a key deliverable for us. We see that the complaints performance is not in the place that we would like it to be, and partly that is related to some limitations on the sort of staffing available, which is linked to some factors out with our control. However, going forward, to improve this, a new complaints manager has been appointed, and this person is in post now and is developing an improvement plan, which will shortly come to me, I hope, so that we can get the percentage performance that we see in the papers today improved and in a better position. So that was the area that I wanted to highlight. And I suppose the key for the IPQR is that instead of always having metrics that are roughly the same at each report, we're able to focus on metrics where we would like to see improvement, and then set about pieces of work to achieve that improvement, and then monitor through regular reporting to see if we are delivering on what we have planned. So that's my brief sort of input there. And maybe pass over now to Gaynor.
Thank you, Boyd. Thank you, David. Nothing to report in terms of the discussion that we had at Clinical Governance Committee on any of the measures, other than to say that we have asked to see some of the data presented in control charts, as David has mentioned previously. So quite a lot of the clinical governance data that sits on our clinical governance dashboard is already in that format. So it'd be good to see that on the IPQR. Thank you.
And Chair, I think Kate was going to mention some national work that was being kicked off, which might have been interest to board members, Kate.
Yeah,
Good morning, everyone. Kate Patience-Quate deputising here today for Heidi May. Just to make reference to the point around the data, we are really encouraged to be engaged in the alignment of some national work around inpatient falls prevention. As you'll see from the report, this has continued to be an area of focus with us in Highland, but recognition from Healthcare Improvement Scotland and work with Scottish Patient Safety Programme and Excellence in Care, that there is now a need to look at this in a Once for Scotland approach and really look at all of the best available evidence to look at further targets in reducing inpatient falls, both falls with harm and those of lesser significance. So we're really heartened to be part of that collaborative and happy to update on that at further point.
Thanks, Kate. I don't know if there are any questions or comments in relation to the clinical governance section of the report before we move on to the next part. I can see Bert, you got your hand up.
Thank you very much. I did want to ask about the complaints, but Boyd has probably answered some of my queries. When the paper talks about the 20-day target not being made for a number of complaints, do we have any idea of how long it is actually taken to complete the process? If it's not being met within 20 days, have we any idea of how long it is taking? Because I noticed in April of 2020, which is a year ago now, quite a number were taking over 100 days. So that's my question. I'm pleased to see that the issue has actually been identified and action has been taken with the appointment of someone to oversee this. So thank you very much.
Thanks. So hopefully I covered some of it, as you say, in my answer earlier. The 20 working days response time is a target, but of course some complaints are very complex and require for complex pathways for care and multiple departments and professionals and steps in that pathway. It leaves you with an awful lot to review. We've also, I think, seen because the second wave of COVID in Highland was much bigger than the first wave of COVID for Highland, we've seen much greater pressure on clinicians in terms of actually their ability to to be free to do other activities beyond directly sort of direct contact patient care. So that has had an effect in this year. And unfortunately, I think we see some of that in some of the data, because much of what has to happen in complaints is centrally handled, but the response is formulated out where the service occurred and where usually the issue has therefore arisen, and the explanation and response will come from there. And of course, to get that pulled together at the same time as there are other significant and unusual, unprecedented clinical pressures, there's been a co-relationship, which is why a year ago we were really improving our performance and then tried to sustain that. But as we got into the latter part of last year and through this year, we've seen that complaints overall performance against the 20-day target drop. So therefore we could look at means and look at what the average time is, and that may be something we'll take away to generate a metric. There will always be a few cases which run much longer for some of the complex reasons I've stated, and indeed certain pathways of care and certain conditions will necessarily be very complex and will always take time. But I do believe that we can work this year towards bettering performance because there will be some elements of complaint response which can improve some of the factors hopefully go away in the course of this year.
Thanks. Boyd, if I can come to Alistair Christie.
Yeah, thank you. My question is on the executive summary. I don't know if you want to take it at this point, David, or...
Yeah, happy to.
Okay. It's probably just me, but I'm struggling with some of the colouring on it. If you look at the new OP referrals, it's showing in green when we're behind plan for that. And I understand that, and obviously there's probably some bad news associated with that, because that could be a bottleneck of cases to come through. But if you look at A&E attendances, again, we're behind plan, but it's shown as red. And I don't understand why for OP referrals, when we're behind plan, it's shown as a minus and green, and for A&E shown as a minus and red. And that's just sort of throwing me a little bit as to whether I'm missing something. So if that could be explained to me, I'd be grateful.
Yeah, thanks, Alistair. And feedback along similar lines has been heard. So I expect this would be the last version of this particular report that you'll see. We will update it to make it clearer for everyone. The red, amber, green was really to reflect variance to plan as opposed to necessarily good, bad, or warning, which is typically the red, amber, green type scenario. So I think it's that's what's probably causing the confusion. But I think given that the case, we'll replace this chart in the next version. So hopefully it'll be clearer. So apologies if that continues to cause confusion. It's true that variance to plan, one, there's a number of reasons for it, and secondly, in terms of pressures on the system, then it changes. I think outpatient referrals, for example, is it good news that outpatient referrals are down? Well, it might be if in terms of the load on the part of the system that's trying to deliver care, but actually for care of the patient, that might not necessarily be a good thing. But equally, we don't know is the answer. And as we come out of COVID, we've seen a number of things happen, and we heard that in terms of the testimony of our primary care colleagues earlier. We're seeing different presentations. It's not necessarily clear whether that's good or bad. Although the one I would point to, and we'll hear about it in a moment, is around cancer referrals. I know that's had a lot of attention in the press. Actually, the referrals for suspected cancer are over 80% above what we predicted. So from that point of view, it's beyond plan, but actually these cases are being presented for further examination. So, but I apologise for the confusion around the chart, but that will be updated. Okay, James, and then I'll move on to the next section. James Brander.
Hello, David. Yes, thank you. Similar question to Alistair, actually. I was looking at the A&E attendance, the figures in red there, and it's my understanding that you're wanting members of the public to think before they go to A&E, and that there are alternative places that they can visit. But that chart gives the impression that you want A&E numbers to go back up. Is that the case?
No, I would argue that's not what it tells you. What it's telling you is that it's different from what we predicted it to be. It's not neither telling us what the strategy is. So the plan is probably more accurately described as a forecast as opposed to something that we are particularly aiming towards. But like you say, James, I think there are other alternatives to A&E. In actual fact, we've seen quite a sharp increase in recent weeks, even since this report was generated, of people attending ED. And actually, what we are very keen to make sure that the other alternatives other than ED presentation are fully explored. before arriving at the ED. That's beneficial both for the patient and actually then meaning that our clinicians are treating those patients with the greatest priority. So there is definitely work that we need to do in terms of education. Sometimes that's working with our partners, both in the ambulance service and in general practice, so that we can get patients treated and allow patients to be treated in the best possible place for them, which is not always ED. Thanks for raising that.
Okay, thank you. Thanks, David.
Pamela, did you want to come in?
Yeah, just to re-emphasise that the policy process is to turn unplanned care into planned care. So absolutely the policy is still to try and pursue that. And I think this one's always been a troublesome one for us because we looked at previous patterns, as David said, and then whether we were in line with previous patterns or if anything had changed. But what you couldn't misinterpret is that we are looking to increase that unscheduled activity, which is absolutely not the case. So that's the reason this report needs a bit more development.
Thanks, Pam. James, it might be your system, but it shows me your hand is still up. So if you're complete with that, we'll move on to the next session, if that's okay. And we're going to look at performance. So I'm going to invite Catherine, first of all, to talk about acute performance, and then Louise to talk around the community performance. And then perhaps you can open up for, and then I'll invite Alex to talk about our governance committee around finance and performance, concentrating on performance for the moment. And then we'll open up for questions after that. So Catherine first and then Louise.
Thanks, David. Just want to bring the highlights to you, and I'm happy to take any questions. Appreciate that. The question that was posed to us, David's already answered that. So yeah, in terms of our position, you can see that we are doing well in terms of our activity levels. As has been noted already, our referrals in for outpatients are lower than planned. Our referrals in for cancer is higher than expected. But actually it was predicted by us that would be the scenario that we'd be working with. And indeed our activity in terms of treatment time guarantees has been lower, and as we know that's because of step down of activity since the beginning of the year. And we are now working to remobilise our services, as Pam has mentioned in her Chief Exec's report, and looking at having all of our theatre capacity back online and up and running by the end of June. So we will start to see some very different numbers coming through in terms of what's presented here. Our biggest challenge, just to highlight, is flow, and I continue to work very closely with Louise and others in terms of the unscheduled care and flow and creating capacity, particularly for medical patient flow, to ensure that we can reserve capacity and ring fence our surgical bed capacity. So a lot of work is going on in relation to that. Our ED performance has not been as strong, particularly in Raigmore, over recent weeks as we would like it to be, and that very much relates to flow into medicine from the emergency department. And again, the work that we're doing around flow will start to see and show benefits shortly. The increased numbers of attendances at the emergency department, and indeed the reduced attendances as we've seen here, we believe those are largely because of lockdown and the numbers of visitors to the area, and we do anticipate that those numbers, and indeed they have started to show a sharp rise now in terms of numbers of attendances at our emergency department. So that's really, David, all I want to say at this point, but happy to take any questions at all.
Thanks, Catherine. If I can come to, before we open up for questions, if I can come to Louise from community and mental health point of view, please.
Thank you. And I think I just want to echo very much Catherine's feedback around the joint working that we're doing between acute community services and that flow. and particularly the positive impact it's had on delayed discharges. Our challenge is how we sustained that, and I think certainly the teams are working very hard to do that, and looking at how we can free capacity for scheduled care by looking at how we do unscheduled care and flow much better. And certainly the teams are taking on that challenge very effectively as we go forward. At the moment, the system's very busy, admissions are increasing, but we are still managing to keep that momentum going, which is really positive. In terms of other areas of community that are reported in the report, clearly our most reported area are CAMS and psychological therapies. In terms of the CAMS data, we have exceeded our remobilisation plan as you'll see on page 43. However, that doesn't necessarily mean that there's an improvement yet in our performance against the national targets, which are set out in page 63. We still are showing a performance level that's not as it should be yet against the Scottish position, and we are showing an increase in our weights as opposed to our referrals in. So there is certainly a capacity demand issue right now. We have, though, been given some additional funding by the Scottish Government, and we're working closely with them at the moment in terms of how we use that money. So it's particularly money for CAMS, but there is some for psychological therapies, and there is the opportunity for us to explore further with the Scottish Government in relation to what our needs are. And certainly there's a change in focus as well. So there's an expectation that we look at those patients in transition from CAMS to adult services and how we best support them. So there's a lot of work going on in the background about how we do that and how we achieve a better position across Argyll and Bute and Highland as a whole. Okay, happy to take any questions.
Thanks, Louise. Maybe if I can invite Alex Anderson just to make any comment at this point around performance, Alex.
Yeah, thanks, Dave. Yeah, we had some very good discussions at the meeting. At the time, one of the areas that we looked at specifically was the issue on orthopaedic service and pain management. So that's something I think that perhaps we should be bringing forward, because we know we've got this contact-centred approach. Catherine mentioned it at the time, which is helping, and we're looking again at how we're improving the pain management side of things. The other discussion we had that was quite useful was on the area of the scheduled care services, unscheduled care services, and how the enhanced community model was helping us through that. So that's the kind of areas that we covered, and just thought I'd highlight that. Thank you.
Thanks, Alex. If I can open up to questions at this stage around those areas that have been covered. We may have answered some of them already, but happy to take others. Jerry O'Brien.
Thank you, David. We've touched on a bit of it. I wanted to ask about the 62-day cancer treatment time, which I'm assuming is very, very heavily linked to the increase in referrals. But I wonder if you could give us a bit more detail and how it's linked also to our underperformance in diagnostic waiting times, and whether there's any particular diagnostic tests which we've got a real capacity issue on. And also in relation to the cancer referrals, do we have any intelligence as to whether that's a backlog which we're addressing, or we actually think we're going to be seeing a sustained 80% increase in cancer referrals? Thank you.
Thanks, Jerry. Maybe I can invite Catherine to address that.
Thanks. Yeah, so we are in a very good position actually in terms of our diagnostics position, and probably from an endoscopy position we are in the strongest position of the majority of health boards. Last year we took a vanguard unit whilst we built a fourth endoscopy room, and our fourth endoscopy room is now created and up and running. So that allows us to continue to have the capacity to deliver from an endoscopy perspective. In radiology, we are challenged, particularly around CT, and we're working closely with Scottish Government, who are going to be providing us with additional mobile capacity to deliver CT services and also MRI capacity. So that's welcome from them, and we're bringing that on site. So that will increase our overall capacity for imaging. In terms of the 62-day target, we've been working very closely on that target. We do have work to do, but we are showing signs of improvement as well. Some of our challenge as we've delved into that has come from the sort of prioritization and the understanding around escalation where capacity isn't available within the services. So we've brought work forward on that, and indeed our cancer lead, Nick Abbott, has been instrumental in terms of helping to challenge some of the behaviours of our clinical teams at the front line and allowing us to prioritise appropriately for our cancer patients. So we believe, Jerry, that we do have a cogent plan that will start to address some of the challenges, but you're right, and I do think that the next revision of this report should evidence our performance against the 62-day target as well. But I don't believe we are lacking in capacity. I think it's about us ensuring that these patients are prioritised, and that is a huge challenge as we start to remobilise all services. Thank you.
Thank you. Thanks, Jerry, for the question. If I come to Bert Donald.
Thanks, David. It's just a question about the delayed discharges. I'm assuming from the table that's shown that this is a snapshot on the date that's given, which is the 21st of April. And if it is a snapshot, I'm just wondering that if this was measured over a period of time and there was a trend that was emerging from that, are these numbers typical? And I suppose following on from that, I notice that if I'm reading this correctly, most of the delays seem to be in Raigmore or North Highland, and I wondered if there was any particular reason for that. I've maybe read this wrongly, but that's just how I see it just now. Thank you.
No, thanks, Bert. I think there are two charts, and I'll ask Louise to make comment in a moment. But there are 2-3 different charts. That some are the chart on page 65 in the papers is the one that looks over time. Both the one in 64 and 66 are indeed snapshots, as you've described. So hopefully that gives you a flavour in terms of where they sit. But Louise, did you want to add further comment?
Yeah, just to say that you're absolutely right about that snapshot in time, but we do get daily data, and we get this snapshot in time weekly as well, so that we can actually get a real picture of where we are. And it is very scrutinised in the service just to see exactly the position and the trends, and we are very aware of any upturn in any direction, and certainly that there is a challenge as well about the flow improving in one area of the system and clogging up another. So we might get improvements of patients coming out of Raigmore, so reduced daily discharges there. But if they're fairly complex still and in community hospitals, we could have a bit of an upturn there. So that's why you see that slight peaks and troughs in the data. And our challenge is to smooth that out as much as we can, so that people do end up in the right place at the right time. And that's very much about how we work with care at home, care home services and community support. So it's getting all bits of the system working effectively that's our challenge, really. And I think the particular reference to it being quite North Highland is again how the system works a little bit differently in Argyll and Bute with the hospital services that they receive from out with the board. So that's why there's a particular focus on our data that we're looking at today.
Thanks, Louise. And you'll see that this is a particular area of focus for us. When you look at the chart on page 65, you'll see that that after lockdown, you'll see the numbers starting to rise. and in recent weeks you start to see that reducing, which is in the outcome of our concentrated work, and Alex had mentioned that earlier. And there's a number of different factors. This is a very complex area where there are a number of different contributors towards the overall performance, and we've got some very dedicated team around this and a program around this to make sure that the changes that we make are sustainable. I mean, you know, I think we should recognise the work that goes on in Argyll and Bute, because really it is exemplar in terms of the performance for Argyll and Bute. There is, and this is as much about teamwork and coordination as it is about capacity. There's elements to which capacity is very important and having it available, but it's also the speed in which you're able to use it. And it takes a lot of coordination to get this right, but we are seeing signs of improvement, but there's still work to go. If I can bring in Susan Ringwood finally on this section, and then we'll move on to the final section.
Thank you very much. Just a quick point, something drew my attention in the reports on page 51, and it's about this campaign to end PJ paralysis, about making sure that people don't, you know, get stuck in those hospital beds. And obviously it's part of this whole thing we're talking about flow, and this hadn't come to my attention at all. I hadn't seen it, and I wondered if you could just say a few brief words about what the PJ paralysis campaign is about and how we're contributing to it. Thank you.
I'll maybe invite Kate if she wants to talk to that, please.
Yeah, thank you, Susan. And just a note that the narrative actually is in the past, and we were delighted to have Professor Brian Dolan lead on a webinar. That webinar will be available if committee members wish to view that on the TURAS platform. And we had a huge number of professionals from a variety of different areas, both within the board and out with the board, to engage in that fantastic learning session. And from that, we are working across the clinical and professional groups just to revisit our philosophy of care within the hospital setting around keeping people active. As you might imagine, there's a slight dichotomy in terms of preventing harm in the hospital setting. And whilst we're very focused on looking at people holistically, we are also looking at a reduction in falls. And what we do recognise as part of that risk aversion, we might not be as good as we need to be around promoting independence within the hospital setting. So it is a really complex area of practice, and we recognise that there's a lot of evidence base to support very small but simple steps in practice that can really change the mindset of both people in hospital, their family members and the staff that look after them. So simple things like encouraging people to wear their own clothes when they come into hospital, rather than, as the strapline suggests, putting people into the patient mode and automatically confining them to bed in a virtual sense by putting them in pyjamas. So there's a whole work stream that we'll be looking at as part of the frailty work and our refresh around inpatient falls prevention, because ultimately, you know, all of these areas of care are so inextricably linked, and we want to make sure that we really are looking at our care in a very personalised way, and the evidence is driving the improvements and change. But very happy, as I'm sure you can tell, I'm a real enthusiast for this area, and very happy to pick that up and provide more information out with.
Thank you, Kate. Thanks for the question, Susan. If we can move on to the final section in this area, I will suggest to look at people and staff governance. And can I invite Fiona Hogg and then Sarah Compton Bishop to make comment around this section, please?
Yeah, thanks, David. So yeah, you'll see that the staff governance section has expanded slightly from its one previous indicator. So this is ongoing work for us to bring some additional metrics into this report. And as we do that, it's really important for us to find the right metrics that will give the board a level of assurance at the right level, whereas obviously all of our workforce data also goes through the staff governance and local management processes. So work in progress, but we've added in some additional absence indicators showing the breakdown between short and long-term sickness, as well as key directorate sickness. You will see from that there has been a further reduction in absence in Highland and nationally in February 2021. There's a number of factors behind that. Obviously, we hope some of that is around, good absence management and good support being put in place for people. But we do know as we move into the final couple of months of the leave year that a large number of staff are taking holiday over that time, particularly in the year we've had, where a lot of people probably haven't taken as much holiday earlier on in the year. We also have seen that with people working who are in office-based roles, who are working at home, typically there isn't as high a level of sickness there. And I think it also reflects that if you think back to February, obviously our services were under a huge amount of pressure at that time, and it was really an all hands to the pump. But it is important that we continue to maintain positive momentum, and we've been doing a lot of work with managers on our promoting attendance policies. We've got new policies through Once for Scotland, and actually we know that you can't change the level of sickness or ill health people have, but actually by putting more support in place around people, trying to keep them at work and trying to support them through their absence and then make adjustments to help them come back to work, that's how we make a positive difference. So I think that's ongoing work, but we're definitely starting to maintain that. We've also added in our turnover rate, and that you'll see there's a whole 2 years worth of data there, and that has gradually been decreasing down from 10.3% in April 2019, and we're doing further work on that through our workforce board. We're establishing a work stream looking specifically at retention, and a big part of that is, as we know, we have an ageing workforce, so how do we support those who are approaching pre-retirement and think about how we could potentially use them in a different way if they want to keep working longer. So there's lots of activity there. The final thing I just wanted to touch on was around our new Culture AMP tool, which I'll talk about more under the culture item, but that will gradually give us a range of additional metrics, including the ability to report on things like wellbeing, diversity and inclusion, and also give us some exit data and onboarding data about people's experience. And we'll be very thoughtful about how we kind of share that data. Obviously, as I said at the start, we want to make sure from a board perspective we give the right indicators to show we're making progress, but I think there are some good sources coming on board. We also will be bringing specific mental health related absence data, but that wasn't quite ready for this month. So happy to pass back to David.
Thank you. Sarah, I don't know if you wanted to add anything to that. It's Sarah here, actually. Yes. Perhaps not. Okay, happy to open up to any questions for Fiona in regard to the staff governance and people section. As you're considering that, Chair, I wonder if it might be better, the finance area of the report we haven't covered yet. I wonder if we combine that with the other finance section where we're looking at 21-22 and maybe cover that as a whole, and maybe do that after the break, because I recognise we're encroaching onto a scheduled break at this point with the change in agenda. But I'll leave that for you to consider at the moment. I see Graham has got his hand up.
Thank you, David. It's a question for Fiona in relation to both the workforce planning and staff turnover trends, about whether, I know it's early days yet after the with the COVID situation, but are you able to pick up any longer term indications of trends in turnover and how that will affect workforce planning?
Yeah, I think I think there's a couple of factors here. I think probably one of our big advantages in the Highlands is our remote and rural location, and ever since COVID kind of hit us, we've actually seen a significant increase in the number of people who want to relocate to come and work in the Highlands and in our Highland Butte, and so I think that is a really positive source of supply for us, and we do see, you know, high quality, even right up to the more senior level roles, high quality applicants and choices to be made. So that's a positive for us. I think we're not yet seeing exactly how the impact of COVID is hitting maybe more of our frontline staff. We do know that there are anecdotal evidence across the UK that some people are leaving the professions earlier, you know, and looking for a different balance. And I think that's probably one of the reasons why the proactive work we want to do around retention, and particularly looking at if people want to have a slightly different type of career with us, how can we support that proactively rather than waiting for people to make that decision. So I think that would be important.
Thank you.
Alex.
Yes, thanks, David. Hi, Fiona, I'm looking at your absence by area chart on page 73. And it's clearly going to be very complicated, particularly when the way that you've broken it down in terms of the areas. Can you give us a bit of an underlying thought of how you've built this up? So, for example, usually you would see in this kind of thing seasonal issues. So you would have flu and what have you in the winter time. Of course, with COVID, that's kind of you've kind of blanked that out for this year. But do you do anything about long-term absence and how that can impact, for example, on the corporate area, which is a smaller number than some of the others in terms of percentages? Can you give us a flavour and a feel for how you built these numbers up? Thanks.
Yeah, so the areas I guess we report on are determined by the sort of structures that sit within our people system. So I think, as you say, we would normally see trends around absence that's higher in winter than in summer. Actually, it's gone on its head this year, because what we've typically found, a lot of the people who would have been off with you know, kind of cold or flu related symptoms have been recorded as COVID related absences. I think the key with any of these data is really about the work that we do at a local level, even below operational unit, to identify trends and themes around that.
Thanks, Fiona. Kate, you've got your hand up. Did you want to come back in for something?
Yeah, it was just to add a brief nugget of good news in support of Fiona's comment, and Sandra McCreary is here from the UHI, but we are delighted to have note that there's a 33% increase in applications for undergraduate nursing students at the University of the Highlands and Islands. So we are working with them, as you would imagine, in a very collaborative way to look at that pipeline, and we're waiting for the figures from the University of West of Scotland, which is our university for Argyll and Bute, but we have no reason to believe that they have not seen a similar upturn in interest for people coming into nursing. So that's fantastic news for the people of the Highlands as well as our graduate workforce.
Thanks, Kate. Good to end on a high note. Boyd, if I can pass back to you, as I say, we can cover finance for last year now, if you like, or we can carry that forward into the next finance section, whichever you prefer.
I think we're needing a break now, and that we should have a 15-minute break and then come back just before 11:30 and resume with finance, and then we go back to Fiona's item on the culture thereafter. Hi Fiona, are you okay now with the connection?
It seems to be, yeah, I think we've been having some power cuts locally, and when the power goes off and on, it seemed to trip. I had another wee glitch there just as I was talking on the governance report, but it seems to be okay, touch wood. So
I've had trouble as well with and people's voices dropping out.
yeah.
Hourly. David, are you happy to go on to with the finance part of the IPQR?
Yes. If you like, what we could do is just flow that straight on to the next section as well. Oh, Dave Gardner's there. Dave, do you want to just take forward between yourself and Elaine, just take forward the last part, the finance section with regard to the IPQR, and then just flow straight into 21-22?
I'm easy if we can do it that way. We were just going to do the whole finance as a whole, Boyd. So we'd just touch on 2021 and then do the budget paper. So if you want to go first, or if you want to finish it off under the IPQR and swap places with Fiona, we're not too bothered.
I think if you do finish off the IPQR, and if you start off and then hand over to Alex, and then go on with your 21-22 item, and then we go back to Fiona.
Okay, so I think Elaine's going to talk to that paper. That's okay.
Yeah, that's fine. There's not an awful lot to say on the finance paper within the IPQR. It reflects position at month 12, which is obviously still subject to audit. So we've handed over the draft annual accounts to our auditors, and that process is ongoing at the moment. Position that's reported as a £700,000 underspend, so that's against a budget of 1,005 million, so an underspend of 0.07%. Challenging as we approach year end because of the allocations that we received from Scottish Government around the end of January and into February. We've had to do quite a bit of work with Scottish Government and also with Highland Council just around some flexibility around the year end to get us to that position. Obviously, once we were clearer on what the outcome of the audit is, we'll be able to see the impact that the £700,000 underspend has in 2021-2022. So just looking at the position across a number of areas, the table at table 1, it's slightly skewed, and that's because of the way that we've got funded in from COVID. We've recorded some of the income against the individual areas, but where it's been more generic spend, it's been taken centrally within support services. So just looking at the partnership, reports a year-end underspend of just short of £3 million, but I think it's fair to say that they've had a very unusual year, and a lot of the services that would normally get delivered by the partnership weren't delivered during 2020-2021, so there was significant slippage there. We also had a lot of costs within the partnership that were subsequently coded to COVID, so perhaps there's an element there where we should have been recording that as a COVID offset, but because of the way that the funding came in, it's all been taken in the round for year end. Within acute services, they're reporting a slight overspend. In the main, that overspend relates to locum cover within both Belford and Caithness General, which I think we've been reporting for quite a considerable time now. And that's obviously something that's been looked at through the RGH programme board, just around how services are delivered there. Savings target for 2020-2021, 28.875 million, and the table in the report shows that we've fully achieved that, but that takes into account just approximately £8 million worth of funding that was received from Scottish Government in respect of slippage within the savings plan. The only other thing really to highlight is that there was no brokerage requirement in 2020-2021. At the start of the year, 8.8 million was identified as a brokerage requirement. But again, that funding, the Scottish Government wrapped that requirement up in the COVID funding package. So we won't have to pay back that £8.8 million. On the capital side of things, we came in right on budget at expenditure of 54.655 million, and that reflects a budget reduction that was agreed with Scottish Government towards the end of December as a result of slippage within the big projects of New Skye and Badnoch and Strathspey hospitals, and also National Treatment Centre Highland, and the funding will be provided for those projects within 2021-2022. Not really a lot else to say on that. As I said, still a draft position as we work through audit, but happy to take any questions.
Okay, thanks, Elaine. Alex, do you want to come in from Finance Committee?
Yeah, thanks, Boyd. Just to highlight the achievement that we made, I think this is actually, they've done very, very well. Two areas: the finance team themselves, Elaine, Dave, and the team have worked very well with the PMO to achieve it. But also want to highlight on the capital side of things, the great work the estates team have done to bring that in and get it done in the time frame that was available to them. That was an awful lot of work to finish that. So I'd just like to highlight that and pass my thanks and the board's thanks to those teams in particular. Thank you.
And I would entirely endorse your remarks. Any colleagues want to ask any questions about the information in the IPQR? If not, we'll conclude this item on the IPQR, and thank you to David for conducting the discussion of the various aspects of the IPQR. It's a work in progress, and you referred to some changes that you intend to make down the line. I think it already gives us a lot more assurance than we had in the past, and we look forward to further development and enhancement of the data that's contained within the IPQR, which is also scrutinised at committee level as well before it comes to the board, where we discuss the more high-level aspects. So thank you, David, and thank you all of the team who contributed today to the discussion of the report. We move on now to the next item on the agenda, which is the financial plan for the forthcoming year, for the year we're now in, 21-22. And I'm not sure if it's David or Elaine that's going to speak to this one. I think possibly Elaine, is it, David?
Yeah, given I need to run about 12 o'clock, I think Elaine's going to cover this one, if that's okay.
Okay, that's fine. Yep. So the paper that's presented, there's two asks of the board. Firstly, to approve the initial budget allocation for 2021-22 and note the savings requirement of 32.9 million, and also to note that further allocations in respect to the impact of the Agenda for Change pay award and COVID-19 are anticipated. So we've submitted a one-year financial plan for 2021-2022, expectation that this will be revisited at the end of Q2, and that's to reflect on the ongoing uncertainties around COVID-19 and the delivery of the financial plan, and also associated funding allocations. The plan, as I've mentioned, requires £32 million of savings to be delivered through the cost improvement programme, so a very challenging CIP for this financial year. And obviously, we'll continue to monitor that savings plan through the Programme Management Office and through the Financial Recovery Board on a weekly basis. So the budget has been built on basis of baseline uplift of 1.5%, and we've also had an additional £16.4 million in respect of bringing NHS Highland within 0.8% of the NRAT parity. So that was an increase that we were expecting this financial year. Within that settlement, there is initial funding to cover the Scottish public sector pay policy, but at that point in time it was 1%. So obviously we've moved on from them, but we're still working with Scottish Government around the funding requirements and how that funding will come in. Within the settlement, there were a number of key policy areas that additional funding was identified for. At the moment, that's still at a national level, with only the mental health and CAMS funding being allocated to board level. So we've recently been notified £2.1 million in respect to that funding. So this is a mix of existing and new funding. So waiting times is something that appears regularly in the funding allocations. When we've set the budget, we are assuming that all costs associated with the ongoing response to the pandemic and subsequent remobilisation of services, and also the costs associated with the National Treatment Centre, will be funded. Paper mentions a little bit about how we've gone about setting the budgets, and I think, you know, historically we take the previous year and roll it forward, but just to highlight some of the things that we're starting to do a bit differently. We're developing the process by basing nursing and midwifery budgets on the NMAP establishment review. So that's something that has been ongoing almost since I started at the work around getting those establishment reviews in place. So we'll be changing how we actually do the budget for staff costs within those categories on that basis. So that's something that we will move to change around Q3 this financial year. And I think as those establishment review process get rolled out across other work groups, we'll start to do things differently there as well. Also, the budgets were rebased at the end of 2019-20, so that's just before we started having to deal with COVID. And I think Dave had highlighted previously that the rebasing exercise set the budgets and put them in a good place, but the way that those budgets were set, or how the basis for setting those budgets, it's now a bit up in the air. As we move through remobilisation, we'll be looking to get those budgets more reflecting of the services that are delivered. And we've also introduced a new process for internal investment and funding decisions, which is in its early stages, but that will allow us to highlight budget pressures and ensure that they're incorporated into financial plans for future years. So the savings gap of 32.9 million, table 1 there just highlights how we've got to that position. We've obviously built in a number of expenditure cost increases and pressures, so they're all detailed within table 2. And as I've mentioned, pay uplifts currently are in at 1%, with budgets will be adjusted once we're clear on the impact of that and what the funding arrangements are going to be. For primary care, we've increased prescribing costs by 6%, and that's based on an increase in cost and volume, and the increase within secondary care is slightly less, and that's based on slippage in new drug development. But we'll continue to review that and place a bit of scrutiny on that, because there is the potential that will be impacted both in terms of supply and costs as a result of Brexit and COVID. So we've identified a number of additional cost pressures. So within table 3, we reference other developments of 21.696 million. £19.1 million worth of that is related to remobilisation and is included within a remobilisation plan, and that reflects the recurring element of the costs that are within Appendix 1. Also within there, we've got the costs associated with NHS Highland assuming the running of home farm, and some aspect of adult social care costs that were deferred from 2020 to 2021 that we need to take the full benefit, full cost from in this financial year. Other non-pay, that again is in relation to adult social care and relates to the National Care Home contract, an uplift with the living wage, and also an uplift to the Children's Services payment to Highland Council. COVID-19 costs, we were asked to report them separately to Scottish Government within the financial plan, and they're detailed at table 4. I think these are at a point in time and are likely to change significantly as we deal with the pandemic throughout the financial year. What those don't include at the moment is actually a recent allocation that we've got for community testing of nearly £5 million, and that's across both NHS Highland, Argyll and Bute Council and Highland Council, and that's been monitored through a working group that's been led by Public Health. Looking at savings, 32.9 million, 3.6% of the budgets that are allocated out, which actually relates to 4.8% of our baseline allocation. So nationally, the savings target across all boards is 4%, with that varying from 0.3% to 10.4%. And 7 boards this year have identified a brokerage requirement, whilst we're not actually identifying a brokerage requirement this financial year. The savings delivery is split across the PMO, the Adult Social Care project that we're working with in conjunction with Highland Council, and there's also an unidentified element there that's likely to come through non-recurring savings. Both the element identified has been managed by the PMO, and the Adult Social Care programme are both currently rated as amber, whereas the unidentified one is rated as green, and we're confident that we'll get the non-recurring savings coming out there. Presented yesterday to the development session just where we were in terms of the savings plan at the moment, and there is work underway to identify other schemes and get them into delivery. Moving on to capital plan submitted 73.527 million, so a significant additional amount from the 2020-2021 financial year, and the details of all those projects are included within Table 6. Main ones again continuing to be Badenoch and Strisby and Skye, and the National Treatment Centre as well. So just in summary, we've submitted our plan to Scottish Government. We've going to be discussing that with them very shortly. It will be reviewed at the end of Q2, but we will continue to make monthly submissions to Scottish Government as we did pre-COVID, but with for the last 12 months, there's been a separate significant element relating to COVID costs, and we'll continue to do that. The indication is that at the end of Q1, the Scottish Government will review the COVID costs across all boards nationally, and they will look at the allocation of additional funding and also the allocation basis for that. Last year, funds were allocated on either actual spend or NMAC or a combination of that. So I would be surprised if we don't have something similar this year. I'm happy to take any questions or provide any other detail.
Thank you, Elaine, for taking us through the various tables and the information in such a clear fashion. Questions for Elaine? I think it's just before anybody comes in. I don't see any hands as yet, but oh yes,
there's two hands. Yeah,
I see two hands up, but I just wanted to comment how wonderful it is that we're approaching year 3 of our financial turnaround, not requiring at this stage brokerage. That's a pretty phenomenal position that we've reached in our financial transformation. Adam.
Thanks, Boyd. Thanks, Elaine. Sorry, I just missed slightly what you said, Elaine, or want just a bit of clarification. In terms of the budgets for the nursing and midwifery workforce, was I right in my interpretation that the budget for this year includes the additional staffing that was identified through the last run of the workforce tools? And then a supplementary question in terms of the AHP workforce that is currently being looked at in terms of numbers and disciplines and so on. I wonder if there's any provision for that if additional workforce is identified as being required as a result of that.
You want to respond now, Elaine?
Yeah, that's fine. On the first one, the budgets don't include it at the moment, Adam. The work's actually just been concluded and it was presented to FRB last Thursday. I think it's going to EDG next week. So the intention is that we will amend budgets from Q3. We've taken the decision for Q3 because that reflects the position that we're in at the moment with recruitment, and it is actually going to take a while to recruit up to the establishment levels, but the budgets will be adjusted from Q3 from that report. From then forward. On the HPs, I'm not sure of the timeline for that, but I know when we've spoken about the nursing and midwifery tool, it is something that we would be keen to do. Yeah, I see Kate's got to come in on that.
Kate?
Thank you, Adam. Just for clarification, as you know, as part of the health and care staffing legislation, all front-facing professionals will be required to do the work around review of their workforce in line with safe staffing. The AHPs are just at the beginning of that journey, and it's very embryonic. There are no nationally ratified tools for that workforce, so we are looking at this work going on at the moment as a test run, and we're not anticipating that there will be any significant changes to the workforce or certainly the budget for this year, and we will be aligning the timescale and the methodology for next year going forward to include allied health professionals.
Thank you, Kate. Jerry and then Anne.
Thank you, Boyd. Probably a couple of questions, and I'll ask them both together. It's probably in terms of the current plan. I wonder if Dave and Elaine might just what their views might be in it if we were to categorise our risk items, though, in terms of additional funding and delivery of savings. A very simple high, medium, low sort of categorisation, just so we can get a feel for that. What I was also interested as well is to use the awful phrase of, we obviously have a plan as of today, but do we have any known unknowns out there which we've just not been able to quantify yet? I think Elaine, I could almost see her brain thinking about when she was talking about the drugs, and I think I would actually be quite surprised if we don't run into supply shortages later on in the year, given the worldwide situation and what impact that might have, or any other service pressures which we know are coming but we've not yet been able to quantify. So not looking for numbers, just more an indication of how our thought process is going for that. Thank you.
Shall I kick off in the first part anyway? Certainly.
Yeah.
In terms of the risk items, I think there's no doubt that there's a challenge in terms of delivery of savings this year. I mean, £32 million, 32.9 is a significant challenge. But when you chunk it down, it becomes less or seems less of a challenge, if you like, in terms of the PMO's got £25 million of a target. There's a £3 million target with council, which is a 50 risk share on that one, and we've got the normal non-recurring target that we have every year, because we have non-recurring benefits every year. So I would say that savings is certainly a very challenging year, and it's probably sitting in amber overall, with the elements of green and the elements of darker amber. I do think that certainly the informal views we're getting from government is, I'm not overly concerned about lack of money around COVID expenditure in particular. We have some uncertainty around remobilisation, which are getting chunked off bit by bit. I know that people like Catherine and Louise are speaking to government about different parts of that, and there may be some risks around that. Going on to things like drugs, I mean, we faced quite a number of short supply drug issues in the year just gone, Jerry. There's quite a number of drugs that just went skyrocketing because of their short supply issues. And you're probably right, that is a big unknown. And if you get a very popular drug that goes in short supply, the impact can be phenomenal. Sertraline went in short supply last year, and the price, I can't remember the ratio that increased by, but it was a significant impact on the primary care prescribing. And it's really difficult, as you know, to account for these days, set up a contingency just in case, and then make more savings and make it even more challenging, or do you deal with those issues as they come up and take mitigating steps as you go along? So I think, does that cover it?
Okay, Alex, and then Margaret.
I thought Anne was in before me.
Oh, sorry, Anne. Sorry, yes, Anne was in. You've jumped off the queue in my list here. Anne first, and then Alex.
Okay, thanks. So a couple of things. Well, three, I suppose. Obviously, to echo Boyd's comments about, how grateful we are for all the hard work that went into the achieving the position that we did last year. and the teams have done a great job on that front. I was really interested in Elaine's comments about and that the number of different ways in which the approach to the budget might be changing. And I'd like to suggest that we have a development session at the Finance Committee at some point where we have a look and hear more about that in some greater detail. So I would welcome that if possible, if Dave and Elaine think that might be useful. But I wanted to come back to the question of risk. So Dave's saying there that he would, be thinking about the challenge, the size of the challenge as amber, or in some cases deep amber. And it's obviously really good, as Boyd has said, and important from a flexibility point of view to be presenting a balanced budget. But given the size of the challenge, given how pressured the organisation is, I just wanted to ask the question, are there any other reasonable options that we could take that would reduce the size of the savings challenge even slightly, while still being able to deliver a balanced budget? What would be the implications? What would be the choices we would be making if we did that? And just if you could clarify the 3.6%, 4% size of the savings we're proposing to make, how does that compare in percentage terms to the last couple of years? Thanks.
Dave, do you want to kick off on that one?
Yeah, I'll kick off that one. I mean, I think go back to the risk side and what we're sitting with right now. I mean, first of all, it's very early in the year, isn't it? We're just finished in May and a month in, and we've already got a fairly healthy pipeline, but we need to see it increasing as the year goes on. We could take some measures such as reintroducing non-paid grip and control and all of those kind of things right now that we put in the early days of financial recovery to try and control expenditure. But I'm reluctant, given we're still not out of COVID, and to put any barriers up that may have an impact on clinical services right now, to be honest with you. We could take the kind of more blunt approach of reducing budgets across X service by X%. But again, reducing a target is a target, and it's actually the actions that we need to do to reduce expenditure, not the removal of a budget, that actually matters. I think boards have options in terms of going forward, depending on where they are on the escalation status as well. Whereas some boards could have the opportunity to use a flexibility of 1% up or over. So we could have set if we were level 3 at 31st March, we could have set a deficit budget, if you like, and not have brokerage. It would be accepted, and you'd have to make it up with the underspends in future years, and that's not classed as brokerage. But we weren't in a position to do that, obviously, in March. So the options are simply to monitor right now, as I see it, to monitor the position every month as we do through FRB, and take mitigating actions if and when we see how things are evolving over the course of the year. I don't know, Elaine, if you have anything else you want to add to that, or even Pam. Sorry, the second part of your question, I've kind of forgotten. Sorry, apologies.
Sorry, I was just suggesting that it would be useful to have a development session at the Finance Committee on the kind of changes that Elaine's talking about there, which, I think it would be very useful and interesting for us to be able to hear a bit more about that.
Yeah, and particularly when it's clearly they expressed that we're looking to move away from incremental budgeting and looking at more needs-based budgeting going forward in years to come. So, yeah, that would be a really interesting session.
Alex, and then Margaret.
Thanks, Chair. I'm looking at table 6 on the capital, and there's an area in there, other schemes, Belford replacement and Caithness General Hospital modernisation. Is there nothing planned in capital for the Caithness redesign project, or is that specifically in operations rather than in capital?
I'm looking at Elaine frantically. So.
Yeah, we don't have anything within the capital plan for it. I see Alan's got his hand up, so Alan's probably in a better position to cover that bit about the estate.
Over to you, Alan.
Hi, Alex. Yeah, what that was is a sum of money, because obviously we're going to need some capital for, I would call it, scheme development in regards to these two projects. So there will be something that we need to put against it. So that's why the figure is there for producing the initiation agreement documents. So we are planning to produce the two initial agreement documents this financial year for both projects. So that was just to cover us financially in regards to support that we'll need in producing the documents.
Sorry, Joe, I didn't have a table in front of me. Yes, there won't be any capital expenditure in the current year, so that's why there's nothing there as the business cases get developed.
Yeah, that's fine, thanks.
Okay, Margaret, and then Alistair.
Thanks, Boyd. I'm hoping this point won't be lost, because it links to what Kate was saying earlier, just around the, hold on, sorry, I'll put my camera on. Just what Kate was saying earlier about the HPs. And I think it was just to say that in terms of needs-based budgeting, I know that this year is too late, but I think there is an agreement there if there are elements of risk identified, and I think there are some elements of risk being identified within HPs, that those won't be sitting till next year, that as a first stage then those would be taken through local processes to see what can be done to adjust staffing. And if that's not possible and there's risk is such that it needs to be addressed, then it will be escalated to Heidi, and potentially looking at unspent vacancy funding for this year to put something temporarily in place. I think the practicalities around it are quite risky and difficult, but it was just to make that point that there isn't an intention that AHPs will wait till next year if there are risks, and I think there are some emerging risks that are coming up. So there is a process to look at that should needs be identified at an early stage.
Thank you, Margaret. Alistair.
Yes, thank you, Boyd. And firstly, could I thank Elaine for such an easy to follow introduction and stepping us through the report. It was really comprehensive and gave me certainly all the information that I needed on that. So thank you for that, Elaine. I welcome the idea of a development session. I think actually it's something that I'd like to attend as well. So if we can make sure when it's circulated, it's not just to the members of the Finance and Forms Committee, because I think it would be useful to all of us to be involved and to be able to get sight of that. Just a couple of things. I don't know if it's for Dave or Elaine, but in the Appendix 2, there is 8.4 million of unidentified savings. There's the 3.9 unidentified cost improvement and the general unidentified. It'd be useful just to know how far advanced they both are in terms of identification of projects. And I do wonder for the social care transformation 3.3, should we not just be showing the NHS exposure to that as a result of the risk sharing agreement, because that will be our share of that rather than the gross number, which I assume is shown there at the moment, before the 50-50 sharing on that. So I think there's a lot in here that gives me assurance in terms of how it's presented and the comments that have been made. But if I could have just a bit on those two unidentified areas and just confirmation of the gross, or is that the gross figure on the adult social care? Thank you.
Okay. Yes, thanks. In terms of the unidentified, we're part of the PMO. We're looking at. I mean, the non-recurring element, Alistair, will always be weighted towards the end of the year when things are more clear around what funding we've got, what funding we've spent, and what's likely to cover that. And there's always a little bit of a roller coaster in that one, and so that'll be geared to the second half of the year. In terms of the if you like, £4 million, just under £4 million PMO savings that aren't yet identified, we're already looking at additional work stream inclusions. One of the ones, for example, that we're talking to eHealth around is a lot of the information coming to us from national work streams is that MS365 does have other benefits that we need to realise. So there's lots of licenses we pay for other things like previously WebEx or whatever that we now need to stop and generate savings on those kind of things. There's travel benefits associated with Teams. I don't think I've put an expense claim in over a year now, given the Teams here. So we need to actually work those out and bring those in as benefits as well. We're also looking at wider workforce potential benefits as well as the existing work streams we've got for medical and nursing. So we're certainly looking hard to expand the work streams rather than put burdens on the existing work streams and challenge it further. So we'll continue to review that over the next month or two, and then again, I guess take stock as to where we are there. And then in terms of the adult social care, I do hear what you're saying, but the bottom line is the savings target sits primarily in NHS budgets. Whilst we may get funding from council, if we don't deliver all of it, and they may well give us some resource towards it, certainly the actual savings target itself will almost, whilst there might be some children's elements to offset some of that, primarily it'll be savings that we have to make within the adult care budgets themselves. So we have to show that savings target against us as an entirety, accepting that the risk of non-deliveries is split. So maybe it's about narrative as we report that as the year goes on to make sure that's clear in the narrative and the forecast.
Okay, thanks, Dave. Any further questions or contributions? If not, we're being asked to recommend acceptance of approval of the budget for allocation for 21-22, noting the savings requirement of 32.9 million and noting that further allocations in respect of the impact of the agenda for change, pay negotiations and COVID-19 are anticipated. Are we happy to approve? Okay, thank you. Thanks to Dave and Elaine.
Thanks, Chair. If it's okay, I need to leave now, if that's okay.
And thanks for your ongoing work, not just for your presentation at this meeting today, and also to Adrian. We had an opportunity to thank him yesterday, but we should recognise that in the board record the contribution, huge contribution that Adrian Ennis has made as a PMO director, and we thank him for his part, his large part in transforming our finances.
Thank
you. We had issues, or Fiona had issues with her connectivity earlier on this morning. So we're now going to go back to item 7. There's a culture programme update, bearing in mind that it is 2 years this month since the publication of the Sturrock report, and that's the context for our discussions. Fiona.
Thanks, Chair, and apologies for my earlier connection issues. Hopefully the temporary power issues we were having locally won't reoccur. So within the papers for the meeting today that you've received, you'll see that we have a number of documents, and this is the second of our more detailed updates on the culture programme that we've presented. So in the pack, you've a summary of progress with the recommendations of the Sturrock review. There's a Word document summarising that, but there's also a separate Excel sheet, and we've provided that separately so you can zoom in, as it's not very easy to read in PDF. We've also included our high-level culture programme plan for this coming year, which is aligned to our strategy and to our board objectives. We've also included our new style of reporting for culture, which will go to the Staff Governance Committee and also to board on a regular basis. And this will be our new format for reporting progress with the key work streams of the programme. We've also got a short update on the healing process following the closure of registrations on the 31st of March. So as board members have had a chance to review all of these, I don't propose to repeat what's enclosed, and hopefully the majority of our session we can dedicate to questions and discussion on the content. It is pleasing to note progress that has been made against many areas of the recommendations that the Sturrock Review made. And I think it is helpful to pause and reflect on what has already been achieved, as our culture change agenda is so large and complex and long-term in nature. It can be easy to only focus on what's still to be done, which is quite significant. And it's not just the delivery under the culture programme that are responsible for these changes. We've started this year with a one-year strategy, vision and values that give us as a board a clear direction. Our executives have already agreed their own objectives for this year, which are aligned to that strategy and objectives for the board. And we're now working on setting those for our senior leaders. Our programme for the year ahead is substantial. There's an emphasis on developing relationships and skills in our colleagues and leaders through piloting and rollout of team-based culture initiatives and our leadership and management development programme. We're also piloting systems leadership development for our senior leaders and clinicians. And the wider work on our 3-year strategic plan and remobilisation agenda will also contribute to these recommendations. Our financial approach that we've just talked about is also part of that culture change, thinking about management of our finances and designing value for money into our services as part of each and every one of our leaders and clinicians' day jobs, along with our PMO approach, is another sign of our evolving culture that we should reflect on. One of the things I'm really excited about is that our listening and learning survey will be rolled out across NHS Highland and the Argyll and Bute Health and Social Care Partnership for 3 weeks in early June. This is going to give us a critical baseline measurement for our culture, telling us what do our colleagues across the organisation experience, what's good and what have we still to work on. We'll be actively promoting this survey in the coming weeks, and we're strongly recommending everyone to fill this out. The more people who complete the survey and tell us how their experiences, the more accurate the results will be, and that can adjust our plans and progress. It's an online survey, app and web-based, and while we will have a link sent out to all colleagues by email, those who don't have regular access to emails in the network will be able to access on personal devices via a website or a QR code, just referencing their pay number, which can be found in their pay slip. So this is a really exciting development for us, and we'll be planning to bring the high-level results of this to July's staff governance and board meetings. It's also good to see that so many participants in the healing process have been taking up the options available to them. You'll note particularly in the report that the uptake and benefit from the psychological therapies provided by Validium so far has been significant. And that's positive to read, and it reflects the principles of healing which led us to set this up. Whilst the registrations for the process have now closed with 309 people taking this up, we've still around 150 people working their way through the process. And so our independent review panels are likely to continue till the end of the year or early next year, and there'll be a full report at the end of the process. We have still got a way to go on our culture journey, and we do need to have some focus on key areas like our people processes in the months ahead, and that's to make sure that we deliver the transformational change that we really need there too. Progress has been a bit slower, but we're now aligning the resources and time to dedicate to this, and we have already had excellent uptake and feedback for our Once for Scotland policy training sessions, and that's a key step forward. I think most importantly, we each need to take responsibility as colleagues, leaders, managers. Each one of us creates the culture when we come to work by how we are, what we do, and how we manage our relationships and react to challenges. Our programme of culture change is absolutely an enabler for that, but it needs each and every one of us across the board to be on board and doing our part in this. And that was one of the reasons why I was delighted to hear last week that some of our colleagues are already using the tools we've been rolling out in Courageous Conversations to make their workplace better. our maternity services in Argyll and Bute have really been role modelling this, and they've embedded, I say, the tools along with the vision and values to produce visuals and positive practices at the start of every meeting. And it was really inspiring to hear that, and we're keen to make sure that everyone across the organisation feels empowered to use the tools and support that's there, and to share how it goes, you know, kind of, and really encourage others, because each of us can take those steps forward. So I'm going to stop there and hand back to the chair for any questions and discussion.
Thanks, Fiona, for that overview. And as you said, we have the papers. To read and to consider. So I now invite colleagues to ask questions or to make any contributions they wish by way of observations. Alex.
Got it. Finally found my unmute button. Thanks, thanks, Chair. Fiona, this is good. I'm looking specifically in the appendices at the back on the programme report and the progress that's being made, both in terms of the programme roadmap that's on page 28 and then the culture programme report that's coming down. Looking at a lot of the ambers that are there, and there's several of them where it says design team being identified, and they're all sitting on a date similar to, 30th of June, 30th of June. It's all the same. That's a concern for two reasons. One is you're going to need an awful lot of resource, because I'm assuming it's not the same design team. And two, because it's the same date all the time, does that the inference is that it's been plucked out of the air, that there hasn't been any real thought as to how long is it going to take to do that. And that might be a bit harsh, but that's from an old programme manager, that's how it reads. So, looking at it, is there more help you need? That's the question. And how can we get you that help?
No, it's a really good observation, and probably we've got across the three work streams, you've seen that actually they're working together on a single programme design, which is what I referenced by we haven't got a catchy title for it yet, but our team-based culture initiative. So there has been a bit of a blocker there, because we're very keen that the sort of leaders and clinicians from within the organisation who've expressed an interest in this are part of that design process. But that has meant that obviously getting them all together and progressing this is probably slightly more challenging, but we do believe, even if the 30th of June might just be slipped, they have now been meeting, they're pulling that together, and we did agree as an executive team, we've got all the necessary funding then in place to be able to kind of access facilitators and other support to kind of land that. I think it's a delicate balance, but it's important that as this is an initiative that's going to be rolled out to every team across the organisation, ultimately, we need to make sure we get that design stage right and we have the buy-in from the people that know what it's like on the ground. But as soon as we've completed that over the next 2 or 3 weeks, we're then able to start putting resource behind that to actually pilot it and operationalize the delivery around it. So I think it is a fair challenge, but I think it's one that we've got a good plan in place for now, and certainly I think we're maybe not on track for the 30th of June, but certainly by mid-July we should have that pilot ready to go.
Boyd, could I just, as a follow-up, on your programme roadmap in there, I can see there's a lot of targets, there's milestone indications, and there's obviously Gantt chart bars of what there is. What I can't see from it is how much of the work has actually been done. So if you can put a slightly different colour in, that would give us a very easy indication to say, yeah, we're 25% through, yes, we're 40% through, which will help us in the long run. Thanks.
That's a great point, actually, Alex, and I think we could add, even although we don't particularly like pie charts, there's something for me about just having a little indicator, around that sort of percentage completion rate. So we'll have a look at that, because we want to evolve these reports to make sure they have the most value. So that's a great suggestion. Thank you.
Susan.
Thank you, Chair, and thank you, Fiona, for the really comprehensive report you've given us. It's great to see the plan there now as well, and really aligned with the intentions and the outcomes that we want to achieve. I particularly like the way the progress report that went to self-governance had been presented. I find it very easy to follow the information in that, and so thank you for that. One question really, in the first appendix, pages 23 and 24, you're talking about the amount of training that's gone on, and also the recognising that things are going to take 2 or 3 years. I just had a concern about whether putting it in the performance management aspect of this into the next stage, 2 or 3 years down the line, is there a risk inherent in leaving that activity to a later part of the plan, knowing that you know how crucial getting performance management appraisal, all of that right, would be to helping us achieve the rest of what we want to see done here.
Yeah, and I think that's a really good observation. I think we've seen this year, we've started off with a really strong kind of intent from the executive and senior manager cohort, and we are encouraging for that to be rolled out down the organisation. I suppose what we've tried to do is not be too ambitious around this in terms of the timescale, because I guess we're working against a national backdrop of when we moved into Agenda for Change, and the current pay deal, which is now completed. It's 3 years. There was always an intent nationally to put some appraisal metrics around that, because the previous KSF had fallen away. I do think that, if in the next sort of over the course of this year and into next year, there's certainly quite a lot of work we can do on this. I'm actually, although it's been in hiatus because of COVID, I'm chairing the national board, which was just about to start in March last year. And I think the secret to us embedding this in the organisation is doing that work to make it easy for people. In my experience, the biggest thing that stops a performance management system being embedded successfully is giving people complicated things to do and lots of work. And we're in a benefit, I guess, that as an organisation, the vast majority of our colleagues work in quite similar roles. So actually, investing some time and money in developing core objectives that can be cascaded out, I think, is the way forward for us in really taking down through the management layers, getting out into the broader organisation. But I'm with you. A robust appraisal process is absolutely the key to having good conversations about performance, and we know not having conversations about performance is one of the triggers for the poor relationships that we sometimes see.
Absolutely, and just a quick supplementary on that, I please, maybe we could hear from some of those staff who have implemented those courageous conversations. You've just heard about the maternity people. That would be a nice thing to have at the beginning of one of our meetings, to hear how people have used that and the difference it's made to their work. I'd be very interested in that if it were possible.
Yeah, definitely. We'd love to do that.
That's a good suggestion, Susan. Adam.
Thanks, Boyd. Thanks, Fiona. Just one comment and one question. The comment is that I share your excitement, I think, maybe not quite as much, about the Culture AMP survey that's going to be going out to all staff in NHS Highland and all Argyll and Bute Council employees within the Health and Social Care Partnership in Argyll and Bute, and the need to promote that, get as much engagement with that as possible. And obviously part of that will be about managers encouraging staff to take the time to fill it in, to help them access IT when there's many staff who don't have routine access to IT as part of their work. So I suppose a shared enthusiasm, a plea that we do all we can to promote it, and obviously help managers to support staff to engage with it. My question is about the report on progress with some of the tools and metrics. I'm looking at page 35, which was about the people processes, and that one is at red, which is obviously a bit of a concern. So I suppose my question is, what reassurance can you give us that that will change over the next period, and that we'll see some progress against that one as well, because obviously that's a significant issue of and confidence in the organisation to make sure those processes run as quickly and smoothly as they can.
Yeah, thanks, Adam. And I think one of the things, as somebody who's worked in a sort of project and programme environment for some time, I am probably slightly over whatever the opposite of optimistic is when we come to do these ratings. I think it's really important to be very transparent about things, and actually if we're not quite on track, there's a mentality sometimes that you stay green until you hit the iceberg, rather than the fact the iceberg's in your line of sight. And I think with the culture programme, it's always important for us to be very transparent if we're not on track. I think with people processes, we have had some resource constraints. I say we have had some activity happening there. I think it is a big focus for us now, and actually we've got some plans around our structure and also our case management tools, which now that we've just completed some other recruitment elsewhere in the HR team, we're going to be able to focus on taking that piece of work forward. We've also agreed we're going to align someone from within the HR team to be kind of dedicated to that. So I think we're definitely got the sort of building blocks in place. Sometimes it's because a lot of people are involved in similar pieces of work. I think sometimes it's important not to have everything kicking off at the one time. You kind of almost need to make sure, because anything that we do, even if we put extra resource behind it in the project perspective, that's then got to land in the organisation. So it's almost important for us to sort of sequence when things are going to be landing in the organisation to make sure there's a bit of capacity to receive it. But I'm kind of confident that that's kind of like our number one priority over the next couple of months, and we should be seeing that back on track when we come back in July.
Okay, I have Margaret and Bert and Jerry now. Maybe if we take the three of them and before you respond, if you
yes.
want, Margaret.
Thanks, Boyd. Thanks, Fiona. It's really good to hear the update. It's just in a similar vein to what Susan was saying. I think we had exactly the same idea, but I was just wondering, in the context of getting staff to share what they're learning so far and how they're using that, if that there could maybe be, and I don't want to cause, the last thing I want to do is cause more work, but I just wondered maybe if an early reflection of what staff are learning and putting into practice might be something that could be done in the same sort of vein as, I don't know, it almost like the sessions like Ask Me Anything, where staff could come along and talk about their experiences to other staff. And because we're always using our leadership and our managers to kind of direct and to give people a focus, and it would be really good if the staff themselves could share what they're doing, because it sounds like there's some really good stuff going on out there, and it would also add a bit more positivity, I think, to the survey as well, if it could be done around that time, so that people are seeing the survey as something that is essentially checking the temperature, expecting that there is change, that this is not us having done nothing and surveying what the culture is now. Actually quite a lot has been done, because what's coming back to me through the area clinical forum is very much that there's an awful lot of plans and actions, but what's actually happening, and there is quite a lot happening, but it's just that it's not maybe that visible to as many people as we'd like it to be. I hope that's helpful.
Thank you, Margaret. Bert.
Thank you.
I think you may be muted,
You're
Bert.
on mute.
Are you hearing me now, Chair?
Yes.
Thank you. Firstly, thank you very much to Fiona for a very comprehensive suite of documents giving us an update on where we are with things. I think she's right in what she said in her input about a lot of focus on what needs to be done, but at the same time recognising what has actually been done. As you'll know, I've been involved in this now for over a year, and I would say that in the past 6 or 7 months, I've seen a lot of things coming together, and a direction of travel now being there, and we know where we want to be going. But we should be under no illusion about the work that still needs to be done. I'm getting some feedback. I don't know if others are hearing that. No. Yeah, there's a lot of work still to be done. I think what is important, I think Margaret remarked on it just a moment ago, is about communicating with staff to let them know what has been done. And I think that communication element is just so important. I think the survey that is about to be undertaken will be hugely important. And is an opportunity for us to make some sort of assessment of where we have reached so far. And as I've said before, trying to get as much participation in that survey is really, really important. The plans to provide development opportunities for leaders and managers, I think, is important as well. So I suppose in summary, I think a lot has been done, and I think congratulations should be offered to those who've been involved in this, but there's a lot still to be done, and it is indeed, as Fiona said, everyone's responsibility. Just my final comment or question, perhaps. There's no reference in the culture update to the whistleblowing standards and where we are in relation to this, but I'm making an assumption, Fiona, that the first quarterly report will be due at the end of June, and it's something that we'll see for the next board meeting. Thank you very much.
Thanks, Bernard. I think that that is the case, that we'll be coming to whistleblowing at the next meeting when we have a report. Jerry.
Thank you, Boyd. Firstly, I would just like to thank Fiona for a very comprehensive report. It was very straightforward to read. I just had a very simple question. I suppose it's just around that aspect of visibility. It's on page 23. I'm looking at in terms of the independent review of recruitment processes, and I'm assuming that those recommendations, where possible, have been implemented. And again, it's just about, are those changes delivering the benefits which we hoped they would do when the recommendations? Because again, I think it's just about that articulating what we have already done, and we are already delivering benefits. And I appreciate it may well be far too early in the process to start measuring benefits, but I think it's important in the context of the discussion we've been having this morning, is that yes, we've got a lot to do, but look, we've already done a lot and it is delivering benefits. Thank you.
Thank you, Jerry. Back to you, Fiona.
Yeah, thanks all. And yeah, I think I'll kind of go backwards on that. But yeah, I think from a recruitment perspective, there are definitely, things that have already taken place. Obviously, one of our challenges has been, in the period since we've done the review, a lot of our recruitment in the first part of the year was very much some of the tactical recruitment around some of the COVID pressures and things like vaccination. But we're definitely making progress with that, and we've got a new head of recruitment who's with us now, and we're bringing the teams together across Argyll and Bute, Caithness and Highland, where they've typically been separate, and that's a real opportunity for us to clearly define a model and support. So we'd hope to report back further on that, but as you say, the implementation, for example, of values-based recruitment, which is being done consistently in consultant recruitment now, and we're also making sure it happens across other recruitment, is really key. We talked yesterday in our development session about the recruitment of some of the sort of senior leadership positions into the acute and community structure, and we've been extending some of the tools like psychometric assessment and the use of stakeholder panels that we've used always in executive recruitment into those to really get a more rounded picture of our candidates. So there's definitely lots more to do, but good progress being made, and it's a key area of focus for us as we, start to ramp up our plans to recruit. I think both Bert and Margaret touched on the issue of communications and how we share the positives of what we're doing, and that's a really important part of the culture programme. There's no point doing things if people don't know about it. And myself and Ruth Fry, our head of comms and engagement, are both quite passionate about this subject, and we're very keen to use that sort of storytelling approach. Let's not just kind of produce kind of corporate documents, etc. Let's actually share the stories of what people have been doing. Let's get them to share their stories, and let's help them to get them out, both inside the organisation and actually externally, because we should be proud of where our colleagues are kind of going the extra mile and really making a difference. And I think that comes back to that very first point that Margaret made around, there's lots of good things happening, but we do still get a bit of people saying, I don't see it, I don't feel there's been change. And I think in combination with that, kind of sharing that story, and our leaders making sure that they're having conversations with the teams about what is happening. I think the other thing that we should all be comfortable to do is when somebody says, well, I don't see anything different, engaging in a conversation about that and asking, well, what is it you want to see? What have you done? How can you support? How can we support making that change? I think sometimes we're a bit afraid to take that next step. We just accept, well, some people have said there isn't change. So I think we've got some work to do as leaders as well, and kind of picking that up and understanding, well, what is it that's not happening that we can help to happen, and how can every one of us play our part in that?
Okay, thank you, Fiona. I don't see any other contributions. I see some.
Pam's got her hand up, sorry.
I see a couple of hangover hands as well, so I encourage you to remove them, please. Pam.
Hi, thanks, Chair. Yeah, really, I think most of what needs to be said has probably been said now in terms of what I was thinking about coming in with. But I guess needless to say, this is just so important for us as an organisation to get to a better place. I think I've said before, that a large organisation that's based on the biggest resources, humans, and the difference that brings to the dynamics and how we all relate to each other. I suspect this is never a job that will ever be done. It's about how we work and support positive relationships on an ongoing basis. And I think, as Fiona said, that we stop and have the conversations when we hear the voices that are either unhappy or indeed happy, so that we can always be understanding what works. I think it has felt, that's